Okay, ladies and gentlemen, the Cannabinoid Symposium will be starting in about 3 minutes. So please kindly take your seats. Thank you. Amy, how do you do it? Every meeting you look younger, haven't you? Okay, ladies and gentlemen, we'll be starting in about 1 minute. We're in a very controversial mode this morning. We're doing opioids followed by cannabinoids. So stay tuned. Okay, thank you, ladies and gentlemen, for taking your seats. This is the symposium on cannabinoids in neurology. And when we say cannabinoids in neurology, we're talking about a drug that was recently approved, a cannabinoid that was recently approved by the FDA, as well as one that is pending in the United States for other indications. The approval was in epilepsy, and the second submission will be in multiple sclerosis. So we will be talking about more than one entity, and briefly we'll touch on other areas of interest for the cannabinoids in neurology as well. I'm Ken Somerville. I formerly worked for Greenwich Biosciences in their epilepsy program, and I'm now, they say, retired, and happy that the organizers have thought to have this, I think, important symposium in an area of extreme interest to clinicians, researchers, and the public at large. We have a wonderful panel assembled for you today of people who have done the clinical research with particularly cannabidiol, otherwise known as Epidiolex. And in that time, we're going to begin with an overview, followed by an in-depth look at the data in multiple sclerosis, particularly spasticity in multiple sclerosis. And then that'll be followed by the recent approval of cannabidiol and the data that supports that in severe childhood epilepsies. Our objectives today are, first of all, to learn about the development program in neurology of the cannabinoids and the rationale for it, and perhaps to learn more about the background of how these cannabinoids have been developed. Then we'll go into the depth of the combination of THC and CBD, known as Sativex, in multiple sclerosis. And then we'll be reviewing the data for that supports CBD in the use of Lennox-Gastaut and Dravet syndromes, as well as some of the other epilepsies that are now being considered. That's my disclosure, and I'm very happy to introduce to you Volker Knappertz, who is now the Chief Medical Officer of Greenwich Biosciences. He has been involved in the approval and in the continued clinical development of cannabidiol in epilepsy, as well as other areas of interest. Dr. Knappertz.
Well, thank you to the organizers of ASENT. In fact, it was a very nice commute for me this morning. I'm trying to get this adapted. Thank you very much. I was just saying it's been a very nice commute for me to work. I usually have to go to San Diego, London, Cambridge, and other places in the world to find my place of work. This happens to be 10 minutes from my house in Potomac, Maryland, so it's really good to be here. Really wanted to share with you some of the corporate overview and about GW Pharmaceuticals. We are wholly subsidiary in the United States is Greenwich Biosciences. It is the same company. For legal reasons, we represent ourselves in a commercial setting in the United States as Greenwich Biosciences, just to avoid any confusion. We have been founded 20 years ago by Dr. Jeffrey Guy, who was a botanist, phytologist. He was a general practicing physician in England for a short period of time, went to France and learned about plant extraction in the French tradition of herbal medicines. And then 20 years ago asked the question, why don't we make medicines out of the cannabis plant? It seems to be a centrally acting class of agents. There are over 100 cannabinoids in the plant. And can we make real medicines, real pharmaceutical products out of what 20 years ago was considered purely a recreational drug of abuse? When they then looked at the history of the co-cultivation and human migration in cannabis, Jeffrey Guy found that all the way back to the Sumerians, there was evidence for use for medicinal purposes, including potentially seizures coming out of the cannabis plant. And further interrogation of the history of cannabis really led Jeffrey to understand that the high THC content was a phenomenon of people in Berkeley, California, and San Francisco, California in the 60s, who not only gave us steel barrels and Napa Valley wine as their extraction techniques, but they also gave us high content THC containing plants. So systematically, at that time in the 60s and 70s, the breeding of the cultivars was conducted to increase the THC content, whereas in the heterozygote hillside type of plants, the ratio between THC and CBD used to be 1:1, and that was the naturally occurring ratio until that time. I guess people in Berkeley and San Francisco at the time didn't want to waste a lot of time on the more subtle effects on CBD, and they went for where they thought the main psychotropic effects were going to be harvested. So this happened 20 years ago. It was always plant-based. All of our plants are grown in England in glass houses. We have acres of glass houses, and at one point replaced 2% of the British tomato production by taking over that as the cash crop instead of the tomatoes, which I think was quickly made up by Spain exporting and the Netherlands to the United Kingdom. We have sophisticated development of good manufacturing processes. We control the soil. There are no heavy metals in our soil. We control the light and the environment. We control the plants. We use Mendelian breeding, no genetically modified organisms. We're world leading in cannabinoid research with the 20-year history that includes the pharmacology of the cannabinoids, the common cannabinoids, THC and CBD, where we have a world-leading clinical pharmacology and preclinical program, as well as research into many other plant-derived, cannabis plant-derived products, including other cannabinoids. We have a global, fully in-house, end-to-end research and development organization, and we have regulatory expertise in many regions in this world, including approvals in over 28 countries around the world for our first product, Sativex, which you'll hear about in a minute, and the recent approval in the United States of Epidiolex CBD, as well as the ongoing final stages of negotiation of our European label for Epidiolex there. We have a growing portfolio of patents and proprietary protection of our formulations, and are continuing to expand our proprietary portfolio. So here I give you some images of our growing facility. We have growing facility in 3 different locations in England. There used to be non-disclosed locations that has recently been changed, but they are in Norfolk, England, and in Kent predominantly. And you'd be surprised that the growing conditions in those not quite so balmy latitudes are actually quite excellent for the cannabis sativa plant. So unbeknownst to many people, it's a hardy plant, and Henry VIII actually ordered to increase the hemp production in England to 1/8 of every parcel of land, because it was used for a lot of industrial purposes, including rope production and other forms of canvas kind of production. The word canvas in the English language comes directly from cannabis. So we have manufacturing facilities that are capable of supplying what we would estimate a large world supply of CBD. We are end-to-end growing, extracting, refining, and then bottling and labeling through a contract manufacturing organization, the final drug product. This is what I am quite proud of, and I really want you to behold. This is our development portfolio. We're deeply committed to the space of neurological and psychiatric conditions. As you can see, Epidiolex has been approved for the rare pediatric form, a genetic form of catastrophic refractory epilepsy in Dravet syndrome, and the similarly catastrophic pediatric onset form of epilepsy, Lennox-Gastaut syndrome in the United States. We will be reporting data on our tuberous sclerosis trial in the first half of this year. This would then be the 3rd relatively rare childhood onset form of epilepsy, for which we will be then seeking supplemental NDA approval. I'm very excited to report that we are going to imminently start a phase 3 study in Rett syndrome, and I'll talk to you about that one in a few minutes. As you know, in the United States, we do not have obtained approval for multiple sclerosis, and it's a privilege to have Professor Doug Gooden from University of California in San Francisco later on talk to you about Sativex and our extensive evidence and placebo-controlled clinical trial experience in the condition of spasticity in multiple sclerosis. As I said, it's approved in over 25 countries for that indication. We have also extensively studied Sativex for conditions of pain, varying from pain associated with rheumatoid arthritis to brachial plexus injury to neuropathic pain, all the way to end-stage cancer patients maximized on opioids, adding on Sativex or placebo, a very broad development program that lasted the better part of a decade. Unfortunately, that whole program has yet not yielded an approval for Sativex in the United States, but there are some approvals and some label language in other countries on pain. It is one of the disconnects that we are seeing now with the societal attention being given to medicinal marijuana products, that it seems almost a certainty on the societal level that THC-containing compounds have an effect on pain, whereas the studies that we conducted had rather mixed results, and it was more difficult to really establish an analgesic effect there. And I think there will be an ongoing theme where we will notice that the data that this company has created has been the cornerstone of some of the claims that are being made in the vernacular world. Moving on, we're very excited about our follow-on cannabinoid CBDV or cannabidiol. It's based on the backbone of the CBD molecule, but has some modifications in its chemical structure and has different ADME properties that could be helpful in certain conditions. We are developing this in epilepsy and with a very heavy focus on autism and autism spectrum disorders. And we also have ongoing efforts in Rett syndrome, and I'll talk to you about Rett, as I said, in a few minutes. With regards to other indications, we've had a very exciting experience in a study with Sativex in glioblastoma. We showed a substantial survival benefit at 1 and 2 years, and we are continuing to evaluate those efforts with glioblastoma. Equally interesting and exciting, CBD has produced a study on positive symptoms in schizophrenia. It's a relatively small phase 2 study, which also yielded positive results. And we're very excited to potentially have to offer a non-D2 modifying agent to the armamentarium in schizophrenia, a disease that, as you all know, has not had any major breakthroughs in many years. We are also starting a study in neonatal hypoxic ischemic encephalopathy with an IV formulation. Very exciting to see that we will be able to try to modify the neuroplasticity very early on in life, and we'll be testing that hypothesis in a very carefully designed and slowly starting program in NHIE, but we'll really are excited to use that condition for which there are really, other than hypothermia, no generally accepted treatments to be able to see whether we can change either the immediate insult of the hypoxia or the regeneration and neuroplasticity ensuing after that initial anoxic ischemic insult. So last year, on June 25th, we obtained approval in the United States for Epidiolex, a CBD containing oral solution with a new mechanism of action for epilepsy not involving the GABA system or the sodium channel system. We have positive data, and this will be shared with you by Dr. Kiva and Van Landingham following my prepared remarks here, from 3 placebo-controlled studies with 6 arms of treatment, 4 arms on the 20 milligram and 2 arms on the 10 milligram dose, all of which met their primary endpoint and many key secondary endpoints. This medication, Epidiolex, is approved in this country for the seizures associated with Lennox-Gastaut syndrome and the Dravet syndrome in patients of 2 years of age or older. It was developed in record time from IND to FDA approval in just over 4 years. This is unheard of, and I haven't seen this in my 20 years of drug development experience within the pharmaceutical industry. A tremendous effort that was, of course, carried by many people who were involved in this. It was designated as Schedule 5 by the DEA, pending our full interpretation of the recently written into law Farm Bill and ongoing efforts of an international group on the descheduling of CBD. This may change and may be descheduled in the ensuing years. There's extensive real-world long-term experience from our large expanded access program, which we used initially to really hone in on the types of epilepsies and the types of seizures that would potentially benefit from CBD. Really a very interesting path that now has gotten the attention of FDA, starting off with a large expanded access program for a unique situation, a unique drug like the CBD-containing Epidiolex. So we studied over 2,000 patients overall in this program. We will also show you some data on the durability of the anticonvulsant effects of Epidiolex from the long-term observations that come out of this vast experience even prior to approval. We then got Epidiolex approved, of course, in June, and then brought it to the market in November. The hiatus was necessary because the DEA required 3 months to issue the scheduling from Schedule 1 at the time as a product of the cannabis sativa plant. By definition, every derivative thereof was a Schedule 1 product, and only the medical use through an FDA label allowed the rescheduling process, which then took the time between the approval and when we finally could make the product available. In Europe, we have added the 4th clinical trial, the 2nd trial in Dravet syndrome, to the file, so that we ensued about a 3 months delay from the original planned path forward. And the reason is that we really wanted to have both doses for Dravet syndrome in the label in Europe. The first study only had 20 milligrams doses studied, so we really wanted to be able to guide with data towards the 10 milligram arm, and therefore we included the Dravet 2 study, which Dr. Van Landingham will also show to you, into the file in Europe. As a UK filer, we also encountered some issues with Brexit. I just returned from the UK on Sunday, and I have to say the country is in a bit of a turmoil with that situation, and we're right in the middle of it, because we had to go from a UK filer to a Dutch filer, create a Dutch entity in the Netherlands in order to continue after Brexit to be in the European context. So these things are progressing quite nicely there as well. Very excited about the next indication we're pursuing, and as I said in my introductory remarks, we'll be having data on this in the first half, so stay tuned. A different population to some degree from Lennox-Gastaut and Dravet, although there are, as you all know, some overlaps, especially to the Lennox-Gastaut phenotype with the tuberous sclerosis, now a genetically defined childhood onset of refractory epilepsy. Tuberous sclerosis affects about 25,000 people in this country. Comorbidities include cognitive impairment, autism spectrum disorder, and seizures in about 70 to 80% of patients, as well as other neurobehavioral disorders, some of them specific to tuberous sclerosis. In our EAP program with TSC-treated patients, there appear to be significant reductions in their seizure frequency and also in some of the neurobehavioral aspects of the condition. The single phase 3 study will read out soon, and we're planning to file a supplemental NDA for this condition. Equally exciting, or maybe even more excitingly, we are initiating a phase 3 study in the rare non-inherited X-linked neurodevelopmental disorder called Rett syndrome, one of the neurodevelopmental conditions whose gene was probably not discovered until right around the Human Genome Project completed in 2000. I think the first time the MECP2 gene locus was described was maybe a year earlier. So one of the very resilient conditions to the genetic detection of its origin. It affects 10 to 15,000 live births in the United States, 1 in 10 to 15,000 live births in the United States, overwhelming and predominantly young girls, and it results in abnormal neuronal development and function. It is a very insidious condition that starts off with a progression in the first 6 to 18 months of life, and then around the age of 3 to 4 years of age, there's a so-called destructive phase with a significant neurodegenerative component. These young girls have abnormal hand movements, and that's how it's usually taught in neurology school, but there's a lot of other symptomatology, including seizures, and neurobehavioral symptomatology that is akin to many of the phenomena seen in autism spectrum disorder. And we chose Rett syndrome because we really wanted to study monogenic orphan diseases that had a phenomenology that was based on one single gene defect, so there was homogeneity as to the etiology of the condition, but had aspects that met the spectrum of neurological conditions that could be amenable to CBD. So what we looked for is a movement element to this, which is the classical movement. Here is the hand wringing in the young girls with Rett. There's a seizure disorder associated with this. We're not looking in our phase 3 trial at the seizures per se, but there are many behaviors, including the lactation, rocking behaviors, tantrums, other behavioral abnormalities like aggression and autoaggression that are more common also in the autism spectrum disorders. And this would be a population where we can really have some good assay sensitivity because it's a monogenic illness. So our single phase 3 study has been accepted by the agency as a single pivotal approach to this condition and will commence in a few weeks. So I'm not going to say much about Sativex other than we put the German package insert from my native country or the package on your slide. The reason is we don't have apparently a picture of the English package, but it is interesting. It's actually very widely used in Germany. I had a chance to talk to some MS neurologists there, and they use it pretty widely, and patients sort of self-select for efficacy. It's clearly a responder drug, so many patients do not like some of the central effects they're experiencing, but about a third of the patients feel they get significant alleviation of their symptoms associated with spasticity and multiple sclerosis. And once people have gone through these trials, these trials of one with themselves, they usually find a dose that works for them if they get relief. It's a clear responder and titration to effect situation. And again, approved in 29 countries outside of the United States. We are in close contact with the agency to find a path forward to bring this to MS patients in the United States. Dr. Gooden will talk to you in great detail about our prior evidence here. CBDV, a very interesting follow-on compound, we believe, to CBD. It's a cannabinoid in its own right with its own individual molecular structure and associated differentiation from CBD. And it has a pharmacology that is not like THC, but more like a CBD pharmacology. It does not engage the endocannabinoid system and the CB1 and CB2 receptors. We are studying it fairly broadly in small but pointed studies of autism spectrum disorder. We are also studying CBDV in Rett. Here we are using a paradigm also looking at the Rett girls that do have seizures and look both at the effects on seizure and the non-seizure effects of that type of pharmacology. We did conduct a study in focal onset, formerly known as partial onset epilepsy in adults. That study had a tremendous placebo effect of 50%, and we found it actually failed and non-interpretable, but we are continuing to look for the right epilepsy indication and seizure indication for CBDV, and are committed to continuing to look for a condition, maybe in the rare childhood onset epilepsy space, where the properties of CBDV would be favorable. We have additional pipeline candidates. We're looking at a THC CBD pharmacology with temozolomide for glioblastoma, where we had quite astounding survival data in a very small study of 22 patients, albeit that was placebo-controlled. We also have orphan drug designation both in Europe and in the US for that indication. Schizophrenia is really one of my favorite indications right now that we'll be pursuing vigorously. We're probably going to find another cannabinoid that has some of the properties that are favorable for this condition. It will probably not be Epidiolex, but we'll be looking at the pharmacology of CBD one more time before we make a determination of which cannabinoid to choose for a pivotal development in schizophrenia, truly a condition that hasn't seen a non-dopaminergic agent work, and this could be a paradigm shift, potentially as add-on therapy or used in people that are non-responsive to D2 modifying agents. And I spoke to you already about NHIE, which will be our first way of getting into the IV formulation, but also to look at more neuroplasticity and neurodegenerative aspects, acute neurodegenerative aspects of the pharmacology of Epidiolex. So these are the milestones. This is a slide I usually show to the people who work a little bit further north of here in New York. So I don't think there's so much to say. We are very busy, a very fast-growing company. We went from about 200 people when I joined 2 years ago to almost 1,000 people right now in the organization. And we have a very ambitious pipeline, a very ambitious timeline. And I have to say, the employees in this company are fantastic in their patient centricity and really in the spirit of bringing these cannabis-based medicines through the appropriate FDA process and appropriate drug approval process to the patients who really will be relying on products that have gone through good manufacturing practice assessments, that have a product quality that is clearly defined, reproducible, and have been tested in clinical trials just like any other approved medication, and therefore has the reliability and the assurances that come with this for patients, families, and their caregivers. So with this, I want to thank you and really leave you with one of the patients who has benefited, which is Iwan here. I think Iwan lives with Dravet syndrome, and he was one of the people that had a fairly remarkable response. Obviously, as with all medicines, this is not a miracle drug. It doesn't completely cure seizures, and it has its own benefit risk. And I think you're going to hear more about this now from Dr. Gooden.
Thanks very much, Volker. We will hold questions for the moment, but there will be a panel discussion and Q&A at the conclusion of the lectures. Our next speaker is Doug Gooden, and he's a professor of neurology at UCSF, and he's also been very active in working with MS. He is a noted expert in the field of multiple sclerosis and has done much of the clinical work with Sativex. So he'll be here to talk to you about that program. Doug?
Thank you very much. It's a pleasure to be here, and what I'm going to be talking about is reviewing some of the data with Sativex and the history of Sativex, and these are my disclosures. Sativex, as Volker told you, is approved now in 29 countries for relieving either spasticity or pain. It's produced by a quality control which is identical to the registered pharmaceutical products. Its quality is derived from cultivated cannabis sativa plants, as Volker indicated, and its delivery is by an oral mucosal spray with an onset of action within an hour. And each spray contains roughly a 1-to-1 mixture of THC and CBD. This is the story of Sativex beginning in the late 1990s with its first regulatory submission in 2003, its first approval in Canada for pain in 2005, and then subsequent approvals throughout Europe. And it's currently being considered by the FDA here in the United States. These are the two compounds which primarily compose Sativex, the THC or tetrahydrocannabinol and the cannabidiol or CBD. The difference, do I have a pointer here? Maybe I do, no? I don't. Is the ring, which is on the lower left side of the molecule, which is closed, the terpene ring in THC, and is open in cannabidiol, which affects its binding properties to the receptors. The cannabinoid composition is due to the fact that there are two codominant alleles, one producing CBD and the other one producing THC. And when the heterozygote plant is cultivated, there's roughly an even profile of the CBD and THC content. These are a listing of the various studies that have been done, starting with phase 1. And you can see in almost all of these studies, there was a significant benefit in improving spasticity. I'm going to be focusing on 2 of those trials, including the SAVANT trial, which is the most recent trial, but it's notable for the consistency of the effect of Sativex on ameliorating the symptoms and signs of spasticity. These are the basic demographics of the patients who've taken part in the study. It's relatively constant over the several different trials, so mean age around 50. The percent women, which is typical for MS, in the 60 to 70% range. The baseline neurologic or numeric rating scale, which I will get into in a couple of slides, was about in the midpoint to slightly lower, and the duration of disease was quite long in the patients who've been studied. This is the numeric rating scale for spasticity. An individual is asked to rate on a scale of 1 to 10 the level of spasticity that they experienced over the last 24 hours, 0 being no spasticity, and 10 being the worst imaginable spasticity. It closely correlates with the patient's global impression of how they're doing clinically, as well as other measures, as we'll talk about. This is a different scale than the modified Ashworth scale, which is itself a 6-point scale and is considered, at least within the neurological community, to be a pretty crude measure of how the patients are experiencing their spasticity. Many of these studies have used what's called an enriched or responder design. In this case, the trial GWS P060 used a interval of 4 weeks in which individuals were given Sativex, and those patients who experienced at least a 20% 4-week responders were then subsequently randomized to receive either Sativex or placebo and evaluated over that treatment, that 12-week treatment window. This was the primary endpoint, which is the change in spasticity scores. You can see there was a marked benefit to Sativex and Sativex with similar baseline scores, and this is now measured as a change from baseline. So this is spasticity scores. The frequency of spasms, again, was improved by Sativex with similar baseline scores. And the change in sleep disturbance was also similarly benefited by Sativex, again with comparable baseline scores. This was the global impression of functional improvement by the physician, not by the patient. And you can see the Sativex-treated patients were left shifted towards the better outcome in comparison to the placebo group. This is the Barthel Activities of Daily Living Index. Overall, there was in favor of Sativex on a global scale, but when you broke it down into individual scales, the patients seemed to benefit on things like mobility, transfers, and functional outcomes in particular. This is the SAVANT study, again, an enriched study design. Responders in this case were defined as having a greater than 30% improvement on the numeric rating scale. There was a single-blind phase A where patients were treated with Sativex, and those who had a response were then continued. There was a washout phase, and then finally a treatment phase where patients were randomized to receive either Sativex or placebo. This was the primary outcome. The percentage of patients who were responders, and you can see the odds ratio was 7, highly significant in favor of Sativex in terms of the response. And these are the secondary outcome measures. The change in spasticity on the neurologic rating scale overall was significantly improved. Pain was significantly improved, and even in this study, the modified Ashworth scale was improved with treatment with Sativex. The EDSS score, which is the global measure that we use in MS clinical trials to look at disability, was not changed, which is not surprising. These are the results over time, and you can see there was a rapid onset of the effect of Sativex over the first 4 weeks of the trial, and this sustained impact over the next 8 weeks, favoring treatment with Sativex in terms of its management of spasticity compared to placebo. Safety and tolerability. These are the adverse events seen with Sativex in the comparative subjects, and then finally the non-comparative studies. Focusing on the comparative studies, you can see that there were an increase in Sativex of various central nervous system impacts, including things like fatigue, feeling drunk, feeling abnormal, dizziness, somnolence, disorientation, and so forth. But these were quite small percentage-wise, even though they were more so than in the placebo arm. In general, these were in single digits in terms of patients experiencing these adverse events. In terms of the abuse potential, because this compound, Sativex, includes THC, this was a study done on drug liking, again, a visual analog scale on how much you like the drug. These are inexperienced cannabis users, and you can see that the two agents, compared with Marinol and Sativex, if the patients were given a comparable milligram dosage of THC, they had comparable drug liking on the scale. This again looks at the outcome of feeling high on the scale, and you can see that comparable doses of THC give comparable levels of feeling high. The important thing here is that most patients only use in the 10 milligram range for treating spasticity, which gives you a much lower level of this sensation of feeling high in comparison to higher doses of Marinol or other THC products. In terms of its impact on cognition, this is in doses or sprays measured per day, and in this study, what you can see is that patients generally used on the order of 6 to 7 sprays per day to manage their spasticity. Not surprisingly, the placebo group used more because they were getting less impact. Looking at the paced auditory serial addition test, the PACEAT score. This is a score which is commonly used in MS clinical trials to assess cognitive function. There was no impact of Sativex on the cognitive function, at least as this was measured by the PACEAT. In terms of depression, again, there was very little evidence that Sativex caused any increased depression in comparison with placebo. So in conclusion, I think Sativex is judged by qualitative measures, including the NRS, the Numeric Rating Scale, and the Modified Ashworth Scale, consistently reduces spasticity as an add-on therapy. I think the improvement is subjectively and blindly confirmed by the global assessments of patients, physicians, and also their caregivers. And Sativex is well tolerated with minimum or minimal psychoactive effects at the standard dosages that are used for controlling spasticity. And that's it. Thank you.
Great. Thank you, Dr. Gooden. You have the rare honor and privilege to be ahead of schedule. So thanks very much. And the burning questions we'll have even more time for at the end in our panel discussion. Our next speaker is Dr. Kevin Van Landingham. Dr. Van Landingham is not only an epileptologist, but he's also been a drug developer for a number of years. And quite honestly, as a point of personal privilege, I don't know how I could have worked on this project without his help. Believe me, he was just really an incredible help to all of us. So he's that unique individual with both industry experience and experience as an investigator. He's going to tell us about the Lennox-Gastaut and Dravet program, which, as Dr. Knappert's told you, received approval last June. So, Dr. Van Landingham.
Thanks, Ken. And I need to recognize and acknowledge Ken's efforts in bringing me in to, at the time, GW Pharmaceuticals. This was June of 2015, and he had launched 4 pivotal trials in the span of about a month and was in desperate need of additional support. And we worked our way through it. And I'm going to present 3 of those 4 studies today. The 4th study, the full results are embargoed until the AAN presentation next month. It's been accepted as a late-breaking presentation and will be made next month. So if you have any questions, I refer you probably to the press release on the Greenwich Biosciences or GW Pharmaceuticals webpage. I also want to acknowledge Ken. Many of you may know his political aspirations lean on the red side. And as I was getting dressed this morning, I realized I left my tie at home. So desperately, I reached out to Ken, and I want to acknowledge this tie, which blends in with my suit very well, but it's a Jerry Garcia tie. So he does have some leftward leanings. I think there's still hope for him yet. So I'll start off the talk with that initial part. My only disclosure is, if I can work that, is I'm a current employee of Greenwich Biosciences. If you ever have any interest in finding out the name of Greenwich Biosciences, just let me know. I'll be happy to share that with you. It does share the G and the W of GW Pharmaceuticals. We're a wholly owned subsidiary of GW Pharmaceuticals. So to review the 2 disorders I'm going to be discussing today, Lennox-Gastaut syndrome and Dravet syndrome, they're both rare and very severe, highly medically refractory or treatment-resistant epileptic encephalopathies. While they both have seizure onset in early childhood, typically in the first year, I'll start with Lennox-Gastaut. The diagnosis typically cannot be made until age 3 to 5 years of age. And that is mainly because of the triad of symptoms you need. It's not only multiple seizure types and progressive cognitive decline or lack of ability to meet development scales as the child ages, but also slow spike in waves seen on EEG. And that's not a permanent phenomena. It's in a limited time span. Many of these children with Lennox-Gastaut may start with infantile spasms. As you're aware, a large percentage of those patients have hypsarrhythmia on EEG. That, in many cases, will evolve into slow spike and wave and then into Lennox-Gastaut syndrome. As mentioned there are multiple seizure types and the different degrees of intellectual disability, and it overall represents about 4% of pediatric epilepsies. Rare, but a proportion of childhood epilepsies. Dravet syndrome, as you're aware, for especially the older neurologist, we call this severe myoclonic epilepsy of infancy, first described by Dr. Charlotte Dravet, and it was finally given her name in the late 80s, and it wasn't until 2001 that the genetic syndrome that's present in 80 to 90% of those patients, a mutation of the SCN1A gene, was recognized. Its onset is typically at the first year of life. Childhood development to that point is typically normal, and it often presents with a febrile seizure, maybe status epilepticus, and progressively gets worse with multiple seizure types being seen. Again, highly treatment resistant. Overall, it makes up roughly about 1 to 2% of all childhood epilepsies in less than 15 years of age. And of those before age 3, it's roughly about 6%. I can work that. This is the trial design for all 4 studies. All 4 studies had a 20 milligram per kilogram per day arm. 2 of the studies, one each in Lennox-Gastaut and Dravet, had a 10 milligram per kilo per day arm. I'll present the 2 LGS studies as well as the 1 Dravet study with 20 milligrams per kilo per arm, matching placebo. The titration phase was 2 weeks to titrate up to a fully 20 milligrams per kilo per day, typically reaching that dose by day 11. If you were to be treated in the 10 milligram per kilogram per day arm, you reach that dose by day 7. Remember those dates, because I'm going to come back to it when we look at efficacy. The primary endpoint was median % change from baseline compared to a 28-day baseline period over the entire 14-week treatment period. The seizure types you can see that we've defined there: drop seizures for LGS, atonic, tonic, tonic-clonic seizures that could have led or did lead to a fall. If they were wheelchair bound, you had to make that judgment. For Dravet, we opened it up a little bit to include tonic-clonic seizures, tonic-clonic, and atonic seizures. I'll give you the proportions of those later. These are highly reproducibly accurately counted while patients are being observed. In contrast to absent seizures, myoclonic seizures, for those of you that have done trials in those populations, you often need video EEG monitoring or some seizure detection to actually count those seizure types. So they were not part of our primary endpoint. We did count total seizures as best as they could be counted, though, and that was one of the secondary endpoints. Of the key inclusion criteria between the 2 populations, you can see a broader age range for the LGS patients, a higher entry seizure frequency of 8 drop seizures per month with at least 2 per week. They had to have a history of slow spike and wave EEG consistent with the diagnosis, and they had to have failed 1 or more concomitant AEDs, either currently or in the past. Dravet, we limited the age range specifically mainly because it's been a much better recognized diagnosis, especially with mutation testing now. Slightly lower seizure frequency on entry, greater than or equal to 4 per month. Diagnosis of Dravet was confirmed by the Epilepsy Study Consortium. So we added an extra level. They had to feel that it was typical Dravet. A panel of 4 pediatric epileptologists participated in that. And again, drug resistant. Key exclusion criteria: current cannabinoid use or use within the past 3 months. Any progressive neurologic or medical illness that might result in death in the next 6 to 12 months. Severe hepatic impairment and use of felbamate within the past year. Again, we didn't want to run the risk of any hepatic or aplastic anemia complications from recently initiated felbamate therapy. Looking at the demographics, you can see in the LGS studies, roughly about 30% were adults. The remaining 2/3 were pediatric, sprinkled mainly between 6 to 17 years of age. In the Dravet syndrome, you can see they're about a third in each age group that were analyzed. The seizure types, as expected with Lennox-Gastaut, the most common seizure type in that is tonic, and the most common seizure type in Dravet is generalized tonic-clonic. And then looking at the seizure frequencies, you can see of the drop seizures in LGS running roughly 70 to 85 per month. And that's a lot of seizures. That's a good 2 to 3 seizures per day. And then on the Dravet side, slightly lower frequency, somewhere around 13 per month, i.e. maybe one to 2 seizures every other day. Additional demographics, looking at the number of prior AED trials and current AED trials. In the Lennox-Gastaut population, roughly about 6 failed AEDs and 3 current AEDs. So a median, you can't add those, but somewhere around 8 to 10 as a median of past and current treatment. For Dravet, it was 4 prior and 3 current. And you can see the breakdown. Most patients were somewhere coming into the study currently taking 2 to 4 concomitant AEDs. Of those AEDs that were most common for Dravet, for LGS, you can see clobazam and valproic acid were commonly used. The third most common was either lamotrigine or levetiracetam. And for Dravet, the third most common was stiripentol, which at the time was only approved in Europe. Few patients in the US might have had access to it, but not many at all. It's recently been approved in the US as well. What's who? Clobazam. It's a clobazam. Benzodiazepine, the brand name in Europe is Frisium, and in the US, the brand name is Onfi. There were also roughly about 20 to 30% or actually 20 to 40%, with alternative non-pharmacologic AED therapies comprising of the ketogenic diet, about 8% across each of the groups, as well as vagus nerve stimulator, about 20 to 30% in the LGS population and 10% in the DS population. Looking at the results now with the primary endpoint, the LGS studies on the left and the Dravet study on the right, you can see that all the arms were statistically significant. Slightly higher response with the 20 milligram per kilogram per day arm. That study was not designed to differentiate between 10 and 20 milligrams per kilo per day. Placebo rates were somewhat variable between the two populations. Looking at the responder rate now, and this is typically that's defined as greater than or equal to 50% responder. I apologize for the figures that you're seeing down below. That's FDA has a preference that this type of figure be presented with quartiles. And as a clinician trying to relay that to patients, the number I need you to look at is in the box above the greater than or equal to 50% and less than 75%. That is what's referred to as the 50% responder rate. And you can see that that's statistically significant. That means that a patient going on this drug will have at least a 50% or greater chance of having seizure reduction. And you can see it's statistically significant there. An additional look was looked at those patients having 75 to 100% seizure reduction. And again, you can see an increased rate in the 20 milligram per kilo per day arm versus placebo. Keeping that same thought now, again, the box on the left is the 50% responder rate, and you can see statistical significance in both the 10 and 20 milligram per kilo per day arm. Now, how you can put those lower figures together, if you add those two together, that is the same thing as the 50% responder rate that I've presented to you in the box above. Looking at it on the right, again, there appears to be a higher response rate in the 20 milligram per kilo per day arm versus the 10 milligram per kilo per day arm. That's the second Lennox-Gastaut study with that 10 milligram per kilo per day arm. This is now looking at the responder rate in the box on the left of the Dravet study, and while you can see there's a slightly higher 50% responder rate in the 20 milligram per kilo per day arm, that did not reach statistical significance at 0.08. The 75 to 100% responder, again, you see a nice response in that population. This is probably one of the more interesting features in an analysis that Volker pushed the study team to go ahead and assess. And we were fortunate. We were probably the first company to use an interactive voice response system to record seizures. Caregivers and patients, if they could do it, were required to report seizures at the end of every day. And so it gave us a chance now to go back and look at the data set and try to analyze exactly when we started to see statistically significant separation between the two. And this is the combined LGS studies with the 10 milligram arm in one study and two arms with 20 milligrams per kilo per day. And you can see that statistical significance was reached typically by the time the patients reached 10 milligrams per kilo per day. And that gave us additional evidence to believe that there is efficacy at the 10 milligram per kilo per day arm. Looking at the single Dravet study we've got, and again, this is a little bit lower, or probably half the seizure rate, or a third of the seizure rate in the LGS population. It takes a little bit longer to differentiate, but it is differentiating by day 10. So this is a drug that early on we thought has a long terminal half-life. We've done additional work now to look at the effective half-life as the drug is initiated, and typically it's within probably 30 hours. So we're looking at, you should be reaching steady state with a dose somewhere by day 2 to day 4 or something like that. And so we're confident now that yes, we're seeing exposures and now response within a relatively short time period. This does not go against the common practice in epilepsy where you titrate to effect to maximize efficacy and minimize adverse events. And that, especially when you've got 2 to 4 concomitant AEDs, often can take additional work by the clinician to work out what's the most effective dose of all the drugs. Discontinuation rates now overall from the population, you can see there's a slight increase in the 10 milligram per kilo per day arm from the LGS study, both in any adverse reaction and transaminase elevation. And these are discontinuations due to these reasons. Somnolence was the next, but not very much at all. The 20 milligram per kilo per day arm definitely had a higher rate. Now those transaminase elevations, these were not often, and most often they were due to meeting FDA-mandated required withdrawal criteria. We learned Ken and I learned quite a bit on how to manage these and how to get our clinicians to manage them. Over time, as we did more and more trials, we were actually able to adjust it and try to give the clinician time to go ahead and, number one, confirm the elevation, and then number two, to see if the elevation might be quickly responsive to any changes you might make in the concomitant dose. I'll give you a little bit more information about transaminase elevations a little bit later in the talk. And again, apologies for the busy slides. These are prepared slides. I'll draw your attention to several lines that appear to show at least differences between the Epidiolex groups and placebo, and possibly between the doses of Epidiolex. So overall, somnolence and GI symptomatology were the most common symptoms, and typically relatively common between both doses of Epidiolex. You see diarrhea is higher, doesn't look that much different than it does in between 10 mg per kg per day and placebo. The transaminase elevations, again, it does look like there's a bit of a dose response, relatively small numbers, but still a dose response. And then a slightly higher rate of infections, and some of those infections did include potentially severe infections such as pneumonia that we're still assessing. Of the rash cases that were in that list, sorry, I should have mentioned that, there were some that looked like delayed hypersensitivity. We did not see any cases of Stevens-Johnson syndrome. Typically, that was a rationale for discontinuation of the patient if it looked like a clear hypersensitivity reaction. The disposition now from the randomized trials, you can see that the discontinuation rate was higher by dose in some of the studies, but appeared to be similar in others. And those that completed the trials, nearly 95 to 100% of those patients chose to go into the open label extension study. So high interest in continuing therapy. Looking at the long-term efficacy of these patients, And again, in some countries, they were only allowed to have 1 year of therapy. We've got additional follow-up. This cut is probably from 2016, so the lower numbers at the 1 year point may, in some cases, be due to some patients had not been in the open label extension for that length of time. There were some dropouts. We've also gone back and analyzed the patients that did achieve out to 1 year and then looked at the efficacy backwards at that point in those patients that made it out that far, and typically the numbers are relatively consistent across the exposure. So no obvious loss of effect over time. The overall safety impressions are very similar to what we saw in the clinical trials. This is purely open label data now. And to summarize, and again, this is a very busy slide, but I'll give you a couple take-home points. The transaminase elevations were seen in a much higher percentage, 13% on Epidiolex versus 1% taking placebo. And some elevations were as high as greater than 20 times upper limit of normal. While we had no patients that had total bilirubin elevations during these transaminase elevations of greater than 2, i.e. met Hy's law, there is a push within FDA to reconsider what the bilirubin elevations need to be for significant consideration. And we'll see what guidance FDA provides probably in the upcoming year to look at that. And it'll probably be a change from baseline. What that percentage will be, I can't tell you. But of the interesting notes, the majority of patients, overwhelming, were on valproic acid, and that appears to be the most common risk factor. Other risk factors included elevations of transaminases prior to the initiation of CBD. Clobazam appeared to have a weak interaction as well. The outcomes, this is probably the most interesting part. Roughly about a third in each of these groups. About a third met withdrawal criteria and had to be withdrawn from the study. About a third improved. We allowed dose reductions of either CBD or a concomitant AED in the setting of an adverse event, and this was clearly an adverse event. Those elevations resolved with those changes, and about a third resolved without any changes. So this is a pretty complex issue that I think you really have to take case by case. The other piece is, while the majority occurred definitely by month 1 and overwhelmingly by month 2, there were occasional cases that occurred a year, 2 years out. And some of these children appear fragile enough. They get a viral illness, they're going to bump out their transaminases. So unless somebody's observing that patient with frequent blood draws, and you can't exsanguinate your patients, if you've got an index of suspicion, you might want to check and might want to make some adjustments in dosage. If there's moderate to severe hepatic failure on initiation, you ought to downward adjust both your titration as well as your maximal end dose. And then there's guidance for transaminase elevations to survey the patients while they're on treatment with CBD. This is a very busy figure here. If you're interested, I refer you to the USPI, the US label for Epidiolex. It'll give you the details in there. Typically, we want people now to be aware of the potential effect of CBD with transaminases and to monitor it and react to it appropriately. I'll finish up with the EAP program and some of our experiences with that as well. And this is really what kicked off the program. Patient 1 had a phenomenal response to this drug, could not get it in the United States. And so the child ended up going over to the UK, got initiated on drug, and then had to come back. And for those of you that are investigators or have been investigators in our trial, my hats are off to you, because I have never seen as onerous a system is running a trial with a Schedule I drug. It is one of the most difficult things to do logistically, and a lot of extra work for the investigators and the sites. They did a phenomenal job. These are desperate physicians, desperate families, desperate patients. And so you can see that program has grown to roughly 950 patients. We had both INDs, standard INDs that the investigators were participating, state INDs, as well as emergency INDs in this patient population. The inclusion and exclusion criteria, I'm not going to go into detail. Several of those were very similar to what we had with our clinical trials. Some information on the right about the various pieces in terms of seizures. The total sample size during this report, and again, this was about 2/3 of the way into it, probably 2016, I think, was this data cut, where it was just over 600 patients. You can see the age range there, tended to be children. Seizure frequency was somewhat in between what we had with Dravet and Lennox-Gastaut, and the dose, the median dose was 25 mg per kg per day, but this trial went as high as 50 milligrams, 50 milligrams per kilo per day in some patients. Looking at the breakdown, you can see roughly about 15% were patients with Lennox-Gastaut syndrome, 10% with Dravet syndrome, tuberous sclerosis, roughly 4%, and then a collection of Acardi, CDKL5, a mixture of Deuce, DIP15Q, and Fires, very treatment-resistant status epilepticus, apparently definitely fever-related, but probably viral in initiation. The etiology at the present time is not known, but probably immunologic. And then a large bucket of other patients, roughly 40% of those patients. You can see the outcomes here running somewhere between high 40s and mid 50s in terms of convulsive seizures to look across the different seizure disorders as well as total seizures. And they were maintained over the time period. And you can see some patients actually having significant reductions of somewhere 5 to 10% were actually seizure-free, which in this population is a phenomenal response. Adverse event profile is quite similar to what we saw with the pivotal studies, with somnolence and GI symptoms being the highest categories. So in conclusion, LGS and DS are rare, medically treatment-resistant epileptic encephalopathies. CBD is a unique cannabinoid without the euphoric effects of THC. Epidiolex demonstrated significant reductions in drop and convulsive seizures in the LGS and DS populations studied. Most common adverse events, I've discussed that with you, typically somnolence, and then GI symptoms with transaminase elevations as well. Safety profile was consistent across almost every program we looked at. And prior to starting treatment with Epidiolex, we've got recommendations on transaminase monitoring to ensure that the initiation and use of the drug can be done safely. Thank you very much.
Yeah, thanks very much, Kevin. That was a lot of data. So I hope everyone's still with the program here. We have time, as it turns out, 15 minutes for Q&A, so don't be shy. All we ask is you identify yourself, your affiliation, and then you can direct your question directly to the panel or to myself. Yes, sir.
Mike Goldavi. So, Kevin, great presentation. Small question. I haven't followed this too closely. Is there an understanding of a mechanistic reason for the transaminitis? There we go. Is it working now?
Kevin, I'll take it.
All right. Let me repeat it. So.
Yeah, repeat it.
All right. So I haven't followed this too closely, but I'm trying. Is there a mechanistic understanding of the transaminitis associated with exposure to cannabinoids?
So it's actually not a transaminitis. It is drug-induced liver injury that we're observing, DILI. And we've investigated this extensively. We have an ongoing program to investigate it. The most foreboding part is that there's true synergy with valproic acid. And valproic acid is known to exert its hepatotoxic effect, or the drug-induced liver injury of valproic acid, through several mechanisms, one of them likely related to interference with the mitochondrial electron transport chain. In very reductionist models, and I have to emphasize these are quite reductionist models using seahorse technology of oxygen tension over human hepatocytes. When you co-incubate valproic acid with Epidiolex or CBD, our API, you do see this additive effect as well that suggests that there could be a double hit on the electron transport chains. Again, this is not established. This is at the research setting, but we're working with world-leading hepatologists or experts in drug-induced liver injury to further our understanding of this. I think what's critical is that there's clearly a dose dependency of the effect, as you saw, and as we also see that by and large, the efficacy seems quite similar between the 10 and 20 milligram dose. We urge people, especially in treating patients that are on concomitant valproic acid, Depakine treatment, to go slow and low in their dosing and really go for the initial target dose of 10 milligrams per kilogram per day.
Hello, Felipe Vial from the NIH. I was curious about the impressive effect of the placebo on this on the reduction of the seizures. So, can you comment on that? Do you think because these families are so desperate and the patients, I mean, with these very difficult to treat conditions, this could be an issue? Is this placebo effect more than what you see in other epilepsy trials?
So Volker wanted me to bring up the point of regression to the mean, but to me, I think one of the critical pieces are as clinical trials progress in almost any disorder, those placebo rates go up. Now, you could raise the question, Amphi just had a trial where they had, I think, a placebo rate of less than 10%. And almost every other epilepsy condition and trial, those, as much as they have in psychiatry, there's been a placebo creep. Something is happening in the populations that is definitely evolving over time. And if anybody could figure that out, I think you'd have a key point of trials, because what it requires you to do is recruit more and more subjects to try to demonstrate a difference between active and control arms, in this case, the placebo group. So I don't have an explanation for the exact. You can see the variability we had in the trials, and I'll let Volker go ahead and speak to the regression of the mean issue.
Yeah, no, I think, look, I mean, placebo response rates are related to a combination of issues in every case, right? You know, there are studies, contemporaneous studies with fenfluramine that have a quite a bit lower placebo response rate, at least as the data have been reported so far, and they were contemporaneously conducted in Dravet syndrome with our studies. So you would think maybe the populations are different by you know, people maybe not being eligible for one trial and the other that had inherent baseline characteristics that are different. We believe expectation was actually quite high. There was a lot of awareness and media attention on cannabidiol at the time, through reports including CNN series and so forth, on the expectation of efficacy. So I think expectation would then be a true placebo effect, but I think we also are looking at some regression to the mean throughout the trials, which I think when you look in more detail at the seizure reductions as they occur within the trial and the temporal profile of the placebo effect, I think it looks like a significant part is regression to the mean, but expectation, of course, plays a substantial role. It's highly variable, Keyvan, right? But you're right, in recent trials, the placebo reductions in epilepsy in general have been going up, but there's some exceptions.
Okay, sir?
Houston. Could you just comment briefly on the proposed mechanism of action for glioblastoma?
Volker, I'll let you take that.
Yeah, it's uncertain, right? So it's been known for quite a while that THC-containing cannabinoid mixtures and extracts have anti-cancer effect and anti-proliferative effects in cell culture and in cancer models. In fact, various THC concentrations in a xenograft model of glioblastoma have shown preclinical effect. How THC exactly does that is unclear, but it's very likely directly mediated through the CB1 effects the CB2 effects on the endocannabinoid system, given that this happens at nanomolar ranges.
So, Volker, is it just the THC you think that's giving the effect?
Well, in our hands, we tested, of course, the 1-to-1 ratio, which doesn't give you micromolar concentrations of CBD, it gives you again equally low nanomolar concentrations of CBD. So we believe it has more of a modifying effect on the THC pharmacology. We believe the primary pharmacology in the anti-cancer arena is the THC pharmacology.
Thanks. The gentleman in the back.
Is this better?
Much better.
Use that one, yeah. Thank you.
Questions for Doug, related to 2 questions ago on the placebo business. You mentioned in one of your last slides that there was blinding, and I may have missed it, but I didn't actually see a blinding evaluation. Were the patients actually asked which arm they thought they were in?
No, they weren't. I mean, but the rates at which those central nervous system effects were pretty low, usually in single digits.
Just following up on the placebo, I would like to put in a push for the placebo effect, because my experience with ataxia people, being the registrar when we had things, is the isolation. And any time they get any kind of attention at all, and that people even understand what they have, is just so rare. So I'd say, let's hear it. Get more of them in, just so they get the attention, if nothing else. Okay. The other question I have is the number of people who get kicked out because they are, can't tolerate whatever. Is that number then included when doctors are giving prescriptions, so they know the percentage of people who will have a negative response to something? I mean, or is it just based on the people who get it, and then they know whether or not, it's bad or good or whatever? What's the number that we get?
So those numbers have both been published in terms of taking into account dropouts as treatment failures. So we've done that analysis. The dropouts are recognized in our publications.
Okay, because that's really important.
Well, I'll remind you that patients randomized to a higher dose with less tolerability are going to drop out. So we don't have the luxury of time during a fixed clinical trial where you're titrating patients to a fixed dose and you're assessing them over a fixed time period to make adjustments that normally would be made in clinical practice. So that's why it's critical with any drug, you titrate up to the lowest potential effective dose, and the rest of it is the practice of medicine. You're trying to find what's the most effective dose at the best tolerability and working your way through that. And so what we publish is what you would expect to see in a clinical trial. And you can take it as that's evidence that the drug works. How it's going to work in an individual patient, you can't predict that going into it. You need to be honest with your patients and say, I think this drug will make you better. It may not. It may make you feel worse. It may make your seizures worse. That's even been reported as well with anti-epileptic drugs. So it's a pretty broad spectrum when it comes to clinical practice itself.
Okay.
We could spend the rest of today talking about how to handle those data. Yeah.
Your age of people tended to stop at 55, and I have a friend with the one where you have seizures. I'm sorry, you know what I mean.
Lennox-Gastaut.
Yeah, and she's 70. She's active, she's had gum problems because of that meds. So I'm just kind of questioning, limiting, I don't know if you did or not, people who are older, because we're all living to be older, if any luck at all. Okay.
Unfortunately, while the threshold was 55, the oldest subject was 46. So again, and I'd like to say that we could study very elderly patients. Patients with Lennox-Gastaut are at much higher risk of premature death. And sudden unexpected death is one of the leading causes of death in both the Lennox-Gastaut population and the Dravet population. So these patients, while they may live into adulthood, their life expectancy is definitely shortened. But you're right, there are occasional cases of individuals that live to be elderly individuals. I'm an elderly person with you.
I think if I just may add, it's really important to emphasize that the safety, especially in the elderly population, that is those above 55, has not been established. And there are some, there's some individual reports of people who have taken not ours but other CBD formulation and in a small IIT study that the effects on the liver may be different. Let's leave it at that. But there are other effects that in addition to the transaminase elevation and the potential for drug-induced liver injury via that mechanism, there may be some other things that affect the biliary system. And so while that's far from certain, I think it's important to emphasize that the safety has not been established beyond that age range.
So,
Yes, sir.
Tony Altar of the Verge Genomics. I have actually a question that relates to the liver. And I think in every study there were concomitant other medications. So I'm not sure any of the data that was presented this morning showed the drug by itself. It was always in the context of other medications. So that brings in the question drug-drug interactions. Do you have any evidence, or did you ever measure circulating levels of the other drugs like the valproic acid or the lamotrigine or the active ingredient in the other drug that was administered to show that those levels were not changed by either of the cannabinoid products? And if you don't have those data, the second question might help elucidate that. Did you look at the side effects which were increased? Are those side effects that are an amplification of those existing drugs to suggest perhaps those drugs' activities were elevated by the cannabinoids?
So look, I'm not going to be able to answer all of your questions on the liver, because we have spotty data, but
Just
we
the
have
blood
studied
levels
it
would be enough.
extensively. So let me just address a few points. There are drug-drug interaction. The most prominent one is with clobazam, and it has to do with the increase in the N-dysmethyl clobazam metabolite that occurs. Clobazam, to a much lesser degree than valproic acid, has additive effects on the transaminase elevations. The main interaction is with valproic acid. The 4-ene metabolite of valproic acid is not altered. We studied that extensively, including in phase 1, very rigorous studies, and there's no effect, no drug-drug interaction effect, and we published those results with valproic acid. So we think it's a pharmacodynamic interaction. We have no monotherapy by design. These studies are adjunctive therapy to what are considered optimized regimens of antiepileptic drugs. But if you look at the permutations, it becomes very clear that that effect is minimally related, modestly related, to Epidiolex itself. When you look at those that are on-off valproic acid, it becomes very clear that there's a synergistic effect on the transaminase elevation when you look at the tables in a pivot form. So we're pretty certain this is an interaction that's mainly driven with valproic acid. There's a partial interaction with clobazam to quite a bit of a lesser degree, and it's dose-dependent, meaning that the elevations are about 3-fold higher, if memory serves me right, with the 20 milligram than with the 10 milligram arm. So it's a 3-way interaction between dose, valproic acid, and to some degree clobazam.
Did you ever look at blood levels of the other drugs, though, to see whether
Yeah,
they
we do
changed?
have population PK data on some of the metabolites, especially the clobazam metabolites. I haven't seen the pop PK data, Kevan, on valproic acid. Are you aware of those levels in the pop PK? I know we have a phase 1 study that was reading out, as I just reported, no interaction with valproic acid on levels or on metabolites, especially the 4-ene metabolite. But Kevan, you want to add to that?
Yeah, we've got a phase 2 study in epilepsy patients that were on valproic acid looking at the drug-drug interaction. And in that study, I believe we are checking, I encourage them to check free levels as well as 4-ene.
Yeah, I think
But I'll be honest with you, I think it's going to revert back to what Volker's getting to, is because those parameters, even in valproate-induced liver injury, have not been consistently demonstrated to be related to it. Some patients can have high levels of valproic acid, high free levels, high ene levels. Is no direct correlation to what the etiology is of the hepatotoxicity. Especially
I'm not addressing the hepatotoxicity. I'm addressing the main effect, the anti-seizure or the antispastic effects. Are those associated in any way with an elevation in those other concomitant drugs?
Gotcha.
between the placebo group and the drug-treated group? That's the question.
Okay, so pharmacodynamic effect on the anti-seizure effects is the question.
No,
The
that's the pharmacokinetic effect. I'm asking, are the levels of the other drugs those patients are normally on, are they different when the patients are treated with your drug versus the placebo?
Only clobazam, and it's only the N-dysmethyl metabolite that has an increase on average about 3.4-fold increase in the N-dysmethyl metabolite of clobazam that has been purported to carry anywhere between 10 and 100% of the parent compound efficacy. There is that interaction which may contribute to some of the additive efficacy that our studies weren't designed to detect. What's really important to say here is that Epidiolex CBD works with and without clobazam, and that the effect of Epidiolex as an anti-ictal agent is independent of the co-administration of clobazam.
Okay, we just have time for one more question, sir. Go ahead.
Sohail Jalbut from Rutgers University. Question for Dr. Gooden.
Yeah, we can't hear you.
Dr. Gooden, question for you. Do you think Sativex affect bladder spasticity? Have you looked at that?
There are effects on bladder function, but that I don't think has been looked at specifically.
And
We did a small trial where bladder function was the primary endpoint, and there were positive effects as well, not just in MS. I think there was consistently trends in the MS trials seeing improved bladder function. I think the slide you showed, Doug, on the Barthel also shows a good patient-reported improvement on bladder function.
But you haven't done it quantitatively.
We did a bladder study, a small phase 2 study in patients with urge incontinence.
And what do you think is the mechanism affecting spasticity? How does it work?
I don't actually know. I have no idea. Do you have any ideas, Volker?
Well, there's multiple possibilities. Again, we believe it's the THC pharmacology mediated through the endocannabinoid receptors, CB1 and CB2 receptors, that modify pyramidal cell input and sort of decrease the disinhibition. The alternative is, of course, that it happens at the spinal cord level, at the lower motor neuron.
Thank you.
Okay, that concludes our presentation. I think our panelists should be given a big thanks for that. Also, for any of you who are going to the NIH HEAL luncheon, it is next door. Thank you all very much.